Esotropia or esodiviation is the inward deviation of one or both eyes towards the nose. Different textbooks describe esotropia using different classification systems. This often makes it quite difficult to remember and apply this classification in examinations and clinical setting. For this reason, a layered and structured approach is more useful. In this lecture, classification will be built step by step so that each patient can be placed logically into a category. First of all, we will classify esodiviations into Esophoria and Esotropia. Then we'll discuss some of the categories of Esophoria. Then finally, we'll classify Esotropia based on its comitancy. After that, based on the mechanism behind the esotropia, we will classify it into accommodative and non-accommodative, followed by distance and near relationships, and finally the onset of esotropia and some special types of esotropia. Before we classify esotropia, one distinction needs to be clear. Not every inward deviation is the same. Some deviations are controlled and appear only when the fusion is disrupted. Others are present even during the binocular viewing. These are termed as the Esophoria and Esotropia. Esophoria basically is a latent inward deviation. It is controlled by the fusional vergence and becomes apparent when the binocular fusion is interrupted.
Clinically in Esophoria, the cover-uncover test will usually be normal. Here we are talking about observing the non-occluded eye for the movement. However, if you put a translucent occluder and observe the eye behind the occluder, if there is phoria present, that eye behind the occluder will deviate and return to straight position when the occluder is removed. Then we have the alternate cover test, which is generally performed after the cover-uncover test. And the alternate cover test is the most dissociative cover test, and therefore it measures the total deviation. It includes both the tropia plus the phoria. Alright, so in case of esophoria, your cover-uncover test can be normal with respect to observing the non-occluded eye, whereas the eye behind the occluder might show a movement to come to a straight position. And the alternate cover test will show you the movement.
Esotropia, on the other hand, is a manifest inward deviation. It is present during binocular viewing and reflects a loss of fusional control. Clinically in esotropia, the inward deviation is present even without dissociation, and therefore it is evident on inspection, and it is also evident on all the cover tests. Esophoria can be classified based on the ability of the patient to maintain fusion. We have a compensated esophoria and a decompensated esophoria. In compensated esophoria, the fusional vergence is sufficient to control the deviation, and such a patient is typically asymptomatic. When the fusional control is inadequate and the deviation becomes symptomatic, giving symptoms like asthenopia, intermittent diplopia, and eye strain, especially during near work, then that is known as a decompensated esophoria. In addition to the control, esophoria is also classified based on the distance and near relationships. This depends on the comparison between the deviation at near and at distance. A difference of approximately 10 prism diopters or more is considered significant. We have three categories over here based on the near-far relationship: convergence excess, divergence insufficiency, and basic esophoria. In convergence excess, the near deviation is greater than the distance deviation. This is because of the excessive convergence. In divergence insufficiency, since we need divergence during distance viewing, so distance deviation here is greater than the near deviation since the divergence is insufficient. And in basic esophoria, the distance and the near deviations are approximately equal. This classification is clinically important and will also be used later when we are classifying esotropia, so remember it. So far we have discussed the latent deviation. We now move from the latent deviations, that is esophoria, to manifest deviation, that is the esotropia. The first step here is to determine whether the deviation is comitant or incomitant. Comitancy refers to the consistency of the angle of deviation in different directions of the gaze. When the angle of deviation remains approximately equal in all the directions, or there's a variation of less than 5 prism diopters only, that is considered a comitant squint or comitant esotropia. Also, remember that in comitant esotropia, the ocular movements are full and free, and this usually indicates that there is no paralysis or no restrictive mechanism behind it. Comitant deviations are usually seen in childhood esotropias. However, there are exceptions. Certain acquired esotropias can also be comitant. Examples here include acute acquired comitant esotropia and acquired non-accommodative esotropia. In these cases, the deviation remains comitant despite a later onset. At this point, just remember the terms. We will be talking about them in detail in a while. Let's also try to understand the types of incomitant esotropia. We can have a paralytic incomitant esotropia or a restrictive incomitant esotropia. The paralytic one is basically due to a cranial nerve involvement, and it is usually the sixth nerve palsy. The sixth nerve, that is the abducent nerve, supplies the lateral rectus muscle responsible for abduction, and therefore paralysis of the sixth nerve leads to loss of abduction and an esodiviation. Restrictive causes of incomitant esotropia are due to the mechanical limitation. These are seen in thyroid eye disease, Duane syndrome type 1, and also post-trauma and congenital fibrosis of the extraocular. The Duane's retraction syndrome type 1 can be identified with limitation of abduction, narrowing of the palpebral fissure on adduction, and esotropia in the primary position. Once a deviation is identified as incomitant, the evaluation is directed towards identifying neurological or mechanical causes of the deviation. Another important point that we must all understand is regarding the dynamic nature of the comitancy. Comitancy can change over time. An initial incomitant deviation, such as in a cranial nerve palsy, may become more comitant in later stages due to adaptation. Also, long-standing comitant deviations may show mild incomitance due to secondary muscle changes. So this variation should be considered and remembered during the clinical evaluation. After comitancy, at this stage, the next step is to assess the role of accommodation. Accommodation and convergence are physiologically linked. Whenever a patient accommodates to focus on a near object, a corresponding amount of convergence is automatically generated. This relationship is quantified by the AC by A ratio, which represents the amount of accommodative convergence produced per unit of accommodation. Based on the role of accommodation, esotropia can be broadly classified into two groups, accommodative and non-accommodative. In accommodative esotropia, the inward deviation is driven primarily by the accommodation and its associated convergence. Accommodative esotropia can be further subdivided into refractive and non-refractive types. The refractive type is the most common type. It is associated with uncorrected hypermetropia. In uncorrected hypermetropes, the image falls beyond the retina, and in order to obtain a clear image, the patient increases their accommodation to bring back that image on the retina. Due to the normal accommodation and convergence link in these patients, this leads to excessive convergence and therefore esotropia. Typically, hypermetropia in the range of +2 to +6 diopters or more may be associated with accommodative esotropia, although the threshold varies between individuals. The Kansky textbook of ophthalmology gives it as +2 or more of uncorrected hypermetropia. The diagnosis of refractive accommodative esotropia is strongly supported by the response to full cycloplegic correction. If the deviation is completely corrected with the appropriate glasses or with full cycloplegic correction, it is known as fully accommodative esotropia. It means that the accommodation was solely responsible for the esodiviation in these patients. If the deviation reduces but does not disappear completely after full cycloplegic correction, it is called the partially accommodative esotropia. This indicates the presence of an additional non-accommodative component which may require further management, including possible surgical correction. The next group is the non-refractive accommodative esotropia. In this group, the accommodation still plays a role, but the esotropia is not primarily driven by the refractive error. The underlying problem here lies in the relationship between the accommodation and convergence rather than the need to accommodate for refractive clarity. Under this, we have two types, the high AC by A ratio variety and the hypoaccommodative type. The high AC by A ratio variety is also confusingly referred to as the convergence excess type. In these patients, a relative small amount of accommodation produces a disproportionately large amount of convergence because of a really high AC by A ratio. As a result, the distance alignment may be normal or near normal in these cases, but the esotropia becomes more prominent at near because the patient uses accommodation at near. So this type often responds well to bifocal correction, which reduces the need for accommodation at near. Don't worry, in our future videos, we'll discuss about the treatment in detail. The second variety of the non-refractive accommodative esotropia is the hypoaccommodative type. In some patients, the amplitude of accommodation itself is reduced, and therefore, to compensate for the inadequate accommodation, there may be an associated increase in the convergence effort leading to esotropia. An important clarification over here is that this is not a direct physiological link between accommodation and convergence, but a compensatory mechanism, and this is less common compared to the other types. So in all forms of accommodative esotropia, the accommodation contributes to the deviation, but through different mechanisms. In refractive types, accommodation is increased to overcome hypermetropia, leading to convergence and leading to esodeviation. In high AC by A ratio variety of the non-refractive accommodative esotropia, the convergence is excessive for a normal given amount of accommodation. In hypoaccommodative states, reduced accommodation is associated with a compensatory convergence effort leading to esodeviation. Thus, although the mechanisms differ, accommodation remains central to all these subtypes, and therefore all of them fall under the accommodative. If the deviation is not significantly influenced by accommodation, it is classified as the non-accommodative esotropia, which we will be discussing next. If the esodeviation is not significantly influenced by accommodation, it is classified as the non-accommodative esotropia. This is a broad and a heterogeneous group, and therefore, for clarity, it is helpful to organize these into clinical categories so that each presentation can be understood logically. We begin with esotropias that occur early in life. Here we have the infantile esotropia and the microtropia, although microtropia can also occur after surgery. Infantile esotropia presents before 6 months of age, and typically here the patient has a large esodeviation, often of constant variety. Microtropia, on the other hand, is a small angle deviation. Even though the eyes here are slightly misaligned, the brain still adapts in a very clever way. It suppresses the central part of the image from the deviated eye, but still uses the peripheral vision from both the eyes together. So some degrees of binocular vision is preserved. Clinically, this is known as central suppression and peripheral fusion. These conditions will be discussed in detail separately. Next are the esotropias that develop later in the life. These are acquired non-accommodative esotropia and acute acquired comitant esotropia. The first one, that is the acquired non-accommodative esotropia, or the AACET, it develops gradually. There is no significant refractive error and no obvious neurological cause in these patients. In simple terms, the eyes slowly drift inwards over time. The acute acquired comitant esotropia is slightly different. Here, a previously aligned patient suddenly develops inward deviation along with diplopia. So the key idea here is a sudden loss of alignment. This condition has 3 subtypes based on the mechanism. The swan type is seen whenever the fusion is interrupted, for example, prolonged occlusion or patching. Then we have the Burians or the Franceschi type, which is associated with a period of stress and illness. And we have the Belchowski type, which is commonly seen in myopic patients with prolonged near work. Prolonged near work can lead to spasm of accommodation, leading to convergence and esodeviation. The third category of patients with esotropia are the ones with secondary esotropia. So some esotropias can occur due to an underlying problem. Here we have the sensory esotropia, consecutive esotropia, residual esotropia, cyclic esotropia, and the nystagmus blockage syndrome. Sensory esotropia occurs when one eye has reduced vision. Because the brain cannot combine images properly now, because of difference in their clarity, the fusion is lost and the eye gradually drifts inwards. This is the sensory esotropia. Consecutive esotropia occurs after surgery for exotropia. In simple terms, the correction overshoots and the eye now turns inwards. Residual esotropia is simply the persistent inward turning of the eye following the corrective surgery for the esotropia. Then we have the cyclic or the cyclic esotropia, which is a unique condition. Here, the patient alternates between normal alignment and esotropia in a regular cycle, usually every 1 to 3 days. So one day the patient has normal alignment or orthotropia, and the next day the patient might be esotropic, and then the day after the patient is again orthotropic. So this cyclic nature basically tells you about the cyclic esotropia. Another special type of esotropia is the nystagmus blockage syndrome. In some patients with nystagmus, bringing the eyes inward reduces the amplitude of nystagmus. So these patients adopt a convergent position which leads to esotropia simply to decrease the amount of nystagmus. So all these are special entities which will be covered separately. Another important way to describe esotropia is by comparing the distance and near deviation. Here we have the basic esotropia, the convergence excess, and the divergence insufficiency. In order to avoid confusion, we will call the convergence excess as the non-accommodative convergence excess. In basic esotropia, the deviation is similar at distance and near, so the alignment does not change with fixation distance. In non-accommodative convergence excess, the deviation is greater at near. In simple terms, the eyes converge more than required for near work even without an accommodative problem. In divergence insufficiency, the deviation is greater at distance. The eyes are not able to diverge adequately for distance fixation. You must remember that normally to look at a near distance we need to converge, and to look at a far distance we need divergence. In divergence paralysis, the pattern is pretty similar as of divergence insufficiency, but the cause is neurological. There may be a limitation of abduction as well. So insufficiency is basically functional, whereas the divergence paralysis is mostly neurological. Convergence spasm can also present as intermittent esotropia. This is because of sudden overconvergence along with accommodation and pupillary construction, and basically represents an overactivation of the near reflex. Another category is the mechanical esotropias or the age-related esotropias. In elderly patients, esotropia may occur due to age-related changes in the orbital tissues. This is seen in the sagging eye syndrome. With aging, the connective tissues that support the extraocular muscles, particularly the pulley systems, they become lax and displaced. As a result, the alignment of the muscles changes, especially affecting the lateral rectus function. This leads to a divergence insufficiency pattern with esotropia more prominent at distance. One important point to remember is that the same clinical pattern does not always mean the same mechanism. A classic example is the convergence excess. This is usually a topic of extreme confusion. Here, the deviation is greater at near, but this pattern can arise from two different mechanisms. In accommodative non-refractive esotropia, convergence excess was due to the high AC by A ratio. This means that even a small amount of accommodation produces an excessive amount of convergence. Under the non-accommodative esotropia, a similar near greater than distance pattern may be seen, but here the AC by A ratio was normal. So here the increased convergence at near is independent of accommodation. Alright, finally the esotropia can be described based on how it behaves over time. Intermittent esotropia appears under certain conditions such as fatigue or loss of attention, and constant esotropia is present continuously, indicating a loss of fusional control. Many esotropias may initially be intermittent and later they become constant. So this is how we classify esotropia. I leave you with this structured flow which you can revise as a simple mental framework. First ask, is it esophoria or esotropia? Next determine, is it comitant or incomitant? Then assess the role of accommodation. Is it accommodative or non-accommodative? If it is accommodative, decide whether it is refractive or non-refractive. If it is non-accommodative, identify which clinical pattern or category it fits into. And finally, describe the behavior. Is it intermittent or constant? If you remember these steps, you will be able to approach and classify most cases of esotropia in a logical and structured manner. And more importantly, you will be able to present clear answers in your examinations. Thank you for watching. If you found this video helpful, please consider subscribing to the channel and help us reach 100,000 subscribers. That's all for today. Thank you and have a great day.